Hello, good evening, everyone. Welcome again for another seminar with the Virtual Global Spine. Um, Tonight, I'll be speaking about spine surgery in octogenarians and my experience and thought treating this growing patient population. So this is a table published by New York State Department of Health demonstrating the average life expectancy per age. So we can see here, for instance, at age 60, the life expectancy for a male on average is about 20 years, and for a female is about 23 years. Going down to the octogenarian age group, so this includes patients up to 119. So octogenarians 80 to 89. You can see for males, the life expectancy, so on average, is about 7 years, and on average for a female is about 9 years. And over time, this will increase. Now, if you haven't read this book, I really urge you to read it. It's a fantastic book. I think it's a genius book by Peter Attia, Outlive. I'm sure most of you have read it. And basically, what he talks about is, health span. And health span is the amount of time humans live without disease, without not being on medications or without a chronic disease. And initially in medicine, without intervention, the health span is definitely, and the lifespan are less so than when you diagnose diseases and start treating them. So he speaks about medicine 2.0 and then medicine 3.0. Medicine 2.0 focuses on disease diagnosis and treatment. And here we don't necessarily increase the health span, we just increase the lifespan by, not necessarily with a good quality of life, by many years just for treating chronic diseases. And now the revolution is into preventative medicine, medicine 3.0, where we're going to have patients who focus on their health, or humans focus on their health early on, and quitting bad or not even engaging in bad habits like smoking, eating healthy, isometric and exercises and so forth. This would increase their health span. And the goal is to have people live longer, healthier. And he speaks about 4 horsemen in his book, and he thinks that all of these preventable horsemen, which he talks about, which are cardiovascular disease, neurodegenerative disease, cancer, and diabetes, all 4 are preventable diseases by modifying or adopting healthy diets, isometric and strength exercises, and not acquiring any bad habits like drinking and smoking. So even by doing those things, you would even prevent cancer. So along the same line, so we're seeing like, okay, on average, an 80-year-old will live about 7 to 9 years. That will be increasing over time. The life expectancy will be longer over time. That's the slide. And we'll be able to treat more patients, healthier patients in that age group who are fit for surgery. Now, this is a good paper looking at Medicare data and the prevalence of spine degeneration or degenerative disc disease. And we can see these are different age groups and against the prevalence of any spinal degeneration. We can see the prevalence is the highest amongst octogenarians ranging between ages 80 and 84. Okay, and the study starts at the age of 65 because that's where Medicare kicks in. Specifically, looking at spinal stenosis, again, the octogenarian age group 80 to 84 is pretty prevalent there compared to other age groups. That's not surprising. Degenerative disease increases with age. The prevalence of that increases with age. You can see on average up to 6.5% of patients above the age of 80 will have spinal stenosis that needs to be treated. Pretty common. Along the same lines, we need not to forget that the prevalence of osteoporosis increases with age. And year over year, the prevalence has not changed overall of any degeneration. But what's interesting is treating or diagnosing or the prevalence even of scoliosis or kyphosis, kyphoscoliosis, spinal curvature has increased substantially over the past decade. You can see it's pretty low and then it exploded here. The reason is it's not the true prevalence. I think we're just diagnosing it, treating it, and practitioners are more comfortable treating scoliosis and kyphosis more than they used to before, combined with the ability of optimizing health of in general, having more patients fit for a big operation and doing it more efficiently and effectively. So I don't think that's a true prevalence. I think it's just a reflection of more diagnosis and more treatments in that age, in that population, scoliosis, kyphoscoliosis. So along the same lines, I think there are four horsemen or four conditions that are more prevalent in the octogenarians than other conditions. I think that lumbar spinal stenosis is pretty common, as it was demonstrated. Degenerative cervical myelopathy. I think type 2 odontoid fractures is a disease of the octogenarians, and much less common, but much more prevalent in that age group is also treatment of a C2 retro-odontoid pannus. I don't want to stop saying retro-odontoid pannus because it's difficult for me to say it multiple times. So I'm going to just say C2 pannus, which is a CPPD pannus and not a degenerative pannus and not necessarily a rheumatoid pannus. We also want to consider in this age group comorbidities, smoking, HbA1c. I'm not going to belabor that. Anytime you want to operate on an octogenarian, you need to ensure that they're healthy enough and they're fit for an operation. Bone health is important, and we need to pay attention to sarcopenia. First, we follow evidence-based medicine. So a quick review of the current evidence of treating spinal stenosis. Touch upon that. Two landmark studies published in New England Journal of Medicine in 2016. One was the Scandinavian study, the 4S study, Scandinavian spinal stenosis study, and the American study by Dr. Gogawala. These were published at the same time in the same journal edition of New England Journal of Medicine. Both were obviously trials looking at treatment of spinal stenosis. The American study looked at that in the context of spondylolisthesis. However, the Scandinavian study looked at it all comers with or without spondylolisthesis, and they also grouped these patients because they're different patient populations and compared decompression only versus decompression and fusion for stenosis. And long story short, let's look at the data here. And here it's important to note that on average, because we always want to extrapolate the best evidence to our patient population, on average here, the age group is about 66 years plus or minus 9 standard deviation. So it doesn't get to the 80 octogenarian age group in both studies actually. However, the Scandinavian study showed that there's no difference in both populations, spondylolisthesis or no spondylolisthesis, treating spinal stenosis. There's no difference in outcome measured by ODI, EQ5D, and VAS score for back pain and leg pain. There's no difference between fusion versus no fusion. So decompression alone, and these were used, and the technique was open techniques only, no minimally invasive, versus decompression fusion. There's no advantage to adding a longer operation, longer recovery for patients with spinal stenosis. On the contrary, and here these are looking at the outcomes here. On the contrary, there was an advantage for the SLIP study, which is the American study, for patients who underwent fusion in addition to the decompression to treat spinal stenosis in the context of spondylolisthesis. So there has been an advantage here just with the SF36 physical component. The ODIs, there was no difference. So there may be an edge to fusion in addition to decompression for stenosis and spondylolisthesis, demonstrated by the American study, not by the Scandinavian study. Now, this is why my only publication in the New England Journal of Medicine, which is a letter to the editor, emphasizing the potential role for minimally invasive decompression. Maybe perhaps it's more effective in maintaining the posterior tension band than an open decompression with the potential of being appropriate for patients with spondylolisthesis because it's more biomechanically advantageous. It preserves more tissue. More recently, the Norton study came out, which is very recent, I think, a couple of years ago, 2 to 3 years ago, demonstrating that decompression without a fusion is enough for degenerative stenosis in the context of spondylolisthesis. So that, similar to the Scandinavian study, findings were the same, and the average age group included was the same. So can we extrapolate these findings to octogenarians? Perhaps. So patients, for instance, this patient who presented with neurogenic claudications, he's 83 years old. He presented neurogenic claudications. He had at L3-4 and L2-3, he had autofusion of L4-5. So typically when we see this kind of patient, we'd say, okay, this looks like let's treat it like an adjacent segment disease with extension of the fusion and a decompression. I mean, that's most people would treat that this way. But this person is an 83-year-old, pure neurogenic claudications, offering him a minimally invasive decompression at these two levels, which is, definitely less disruptive than an open laminectomy. He might get away without a fusion, and that's what happened to this patient. He had this minimally invasive decompression at these two levels adjacent to a fusion, and he did very well. I saw him for his follow-up 6 weeks later and never heard of him and never heard from him. So he did really well outpatient surgery. So octogenarians, lumbar stenosis equals minimally invasive decompression. Fusion if there's certainly overt instability. Switching gears to cervical spondylotic myelopathy, another prevalent pathology in the octogenarians. When to operate and what's the approach? When to operate is obviously moderate to severe and severe cervical myelopathy by the MJOA criteria. Mild or asymptomatic stenosis, you can certainly watch these patients, and these are the guidelines published years ago. So I'm not going to go into that, deep into that. There's another virtual global spine seminar dedicated to that. So approaches, anterior versus posterior versus front back. This is a good study. I always cite it. It's actually one study that combined two cohorts. It's an AO study led by Dr. Feelings that combined two cohorts, the AO spine cervical spondylotic myelopathy in North America and the international one. So two cohorts, I looked at them longitudinally, and they analyzed the data through propensity match score analysis. Here are the results. So all comers who underwent anterior surgery versus posterior surgery being compared, you can see on average, patients undergoing posterior surgery, which is a posterior decompression fusion mostly, the laminectomy only and laminoplasty numbers were very low in this study. So most of these patients underwent a posterior decompression fusion. So on average, the posterior group is about 10 years older than the anterior group, not surprising. The number of levels, multi-level disc disease is definitely more prevalent in the posterior group. Single level disease was more prevalent in the anterior group. Not surprising. Posterior pathology was more prevalent in the posterior group. So all these prior to matching or prior to matching, just looking at the data as a whole, on average, a patient who is undergoing a posterior cervical surgery is 10 years older on average than an anterior surgery, which is mainly an ACDF or a corpectomy. And these groups are very different. So after matching, you can see the average age decreases, becomes the same. And we can see on average now, the multi-level disc disease is the same. And there's no difference in outcomes. So in my experience, that's correct. So in octogenarians, the patients that I see, for every 3 or 4 patients undergoing a posterior surgery, maybe I'll find one who's fit for an ACDF, just because multi-level disease is more prevalent in this age group, octogenarians, and also patients in the 75 or older. Moving forward, this is another study. That's a trial that was published in JAMA. All of you know about it. We spoke about it before. And this trial include randomized patients into anterior versus posterior surgery after meeting um, clinical equivalence. And you can see the inclusion criteria: 45 to 80 years old, a patient with cervical myelopathy, 2 or more levels, and or 2 or more levels of spinal cord compression. There was also exclusion criteria, not a high cervical sagittal vertical alignment, and no OPLL. So these patients were excluded. Looking at the data too, the mean age group in both cohorts, 60 years old, plus or minus about 8. So I believe that probably not a single octogenarian was included in this study. And the results were anterior or posterior, SF36, physical, as there's no difference. There was an edge for laminoplasty, but that was not the primary outcome. So again, for octogenarians, these are 2 octogenarians I treated over the past couple of years. Multi-level disease. This patient underwent a C2 to T2 decompression fusion. This lady, because she had rheumatoid arthritis, and I went front back on her, but definitely the approach also included the posterior approach. I left these levels alone, just treated the symptomatic ones. Here's another patient. Another note I want to make another note in terms of treating this patient population. Always look for tendon stenosis. Examine the patient. They have a Hoffman's, numbness in their hands. They complain of other upper extremity symptoms. Image the cervical spine, and it's pretty prevalent, finding cervical stenosis along with lumbar stenosis. So this patient presented with dexterity issues, gait imbalance, as well as neurogenic claudications. We treated the cervical spine first with a posterior posterior decompression fusion, and then once he recovered from this, he underwent a lumbar laminectomy to treat his lumbar stenosis, and he did fantastic. Moving on to type 2 odontoid fractures. Now, I want to see if who's managing. I saw Alex. Alex, how's it going, man? Anyone on the feed here? Any questions? Okay. Chat box. Okay, no questions. Great. All right. The third horseman is type 2 odontoid fractures. Okay, let's talk about it a little bit. This is a paper that my group published, led by Dr. Michael Cloney. And this really, a lot of people were interested in this paper because it was a propensity-matched analysis in patients undergoing surgery versus no surgery for type 2 odontoid fractures. For actual odontoid fractures, looking at non-union myelopathy and mortality. So we studied 300 patients. Most of them had type 2 odontoid fractures. And after propensity match analysis, patients who underwent stabilization surgery, a posterior fusion, had a significant advantage in terms of fracture healing, as well as 30-day, as well as neurological outcome, as well as mortality. So the mortality in the fusion group was 1.7% versus 13.8%, and that's pretty surprising. However, there's a reason behind it. So for all comers, only 20% of patients underwent surgery. Okay, and then as I mentioned, the cohort mostly included patients with type 2 odontoid fractures. And the average age group in our cohort, so the surgical cohort was 67.4, and the non-operative cohort was older, about 8 years older. That's not surprising, but after the propensity match analysis, definitely both the age will be the same, and it was about in the 60s. So really, you can't extrapolate too much to octogenarians, but treating unstable C2 type 2 odontoid fractures has an advantage in terms of 30-day mortality, 1-year mortality, and non-union. And why do patients pass away who are treated without an operation? Cardiac arrest is a big one, intracranial hemorrhage, dementia, and stroke. So here's the patient who's 83, female, fell, and neurologically normal. So this patient was placed on a Miami J collar for 3 months. That's her 6-month X-ray upright film. No neck pain, and I'm comfortable removing the Miami J collar. I sometimes repeat the CT scan to demonstrate healing, but a lot of these patients will have fibrous union, in my opinion. However, don't be scared to treating a patient like this. 80-year-old man with Parkinson's disease, felt neurologically normal, and he had the C2 displaced fracture, as well as C1 4-point ring fracture. You can see also that the spinal laminar line here is displaced, right? Like it's posterior subluxation of the C1 ring complex with the fracture fragment. So clearly an unstable fracture. This we're not going to put in a neck collar. Talk to the patient, counsel them, counsel their family, and then treated them with a cervical fusion because of the C1 fracture. You can get away with a C1 fusion, C1 C2 or C1 to C3, but this I felt it will have to go. Plus he was very stiff, not too much neck motion, so did fantastic. So no issues. He healed and he followed up in clinic. This is another patient who is 83, cardiac patient, displaced type 2 odontoid fracture, underwent a C1 to C3 fusion with a cross-link. Did fantastic. You can see here the fracture fragment here is perfectly aligned here. Same thing with the previous case. And the way to align it is to just put them a little bit in flexion, just a little bit, tuck them in. And this way you can realign the spine just with positioning. Last but not least, this may be a quick virtual global spine seminar. It's the C2 pannus, very prevalent, the degenerative pannus in octogenarians. I probably treated in the past years over 10 patients, octogenarians, with this type of pathology. Typically, patients they present with upper neck pain. Sometimes it's painless, as well as cervical myelopathy. And you see here a pannus behind C2. It's almost always CPPD. And the treatment is usually a C1, C2 decompression fusion, rarely going to the occiput. So you can see after the fusion and stabilization, I always decompress. Always there is resolution of the pannus every single time. What's the earliest time frame for this to resolve? The earliest is 6 weeks. 3 months, every patient would have a MR that looks like this. What's your experience, Alex, with these kind of patients?
So, Nader, almost I'm on the other side of the Atlantic Ocean, but I don't have any other opinion like you have. I would do exactly the same. I found it interesting that we have had a host from India, Dr. Deepankar. He's an excellent surgeon as well. He just fuses this without decompression. So he will not take away the arch of C1. He would just do the fusion, and he relies on the vanishing pannus and let's call it indirect decompression. But I do the same. I take away the atlas arch, the posterior arch of atlas. What I sometimes find it difficult to find enough bone for the fusion mass, but I exactly have the same opinion and experience, and my patients do quite well. And I love these MRIs post-op after 3 months, after 1 year. I don't know why I do these MRIs, but I'm always excited every time I see these MRIs because this huge mass is vanishing completely.
Yes. Yeah, because of their significant compression, also for learning, that's why I repeat it. And some patients will have some persistent symptoms, like, yeah, I still have my balance issues and just want to make sure you got the job done. Yeah, that's the philosophy actually of fusion only is a tool go well. So I think that's where our guest philosophy of treatment. The reason is decompression because that's immediate. Like the pannus is not going to resolve the next day, right? It's going to take a few weeks, perhaps a few months. So you want to always offer an immediate decompression, like we do with cervical myelopathy, right? Like maybe when you fuse a patient with cervical myelopathy, the discs in the front. I mean, Ali demonstrated that in many tweets. The discs ossified at the front, they will resorb, right? Like, but what's the time frame? So you want to offer them a decompression. That's immediate relief.
Absolutely.
Yeah.
Nader, I absolutely agree. But the only difference between a subaxial myelopathy and this is the extreme amount of motion that
Right.
is present in C1, C2.
Yeah.
So every rotation
Mhm.
can lead to an irritation of the spinal cord in that area.
Right.
So it's a unique anatomy, and maybe fusion is enough. My only question is, what if not? What if the patient wakes up and
Right.
he's worse than pre-op? Then I am the one to blame.
Yes, 100%. Absolutely, yes. Absolutely. When you repeat an MR, it's still super tight. It's like, what have you done, right? Like nothing. So that's an important point too, because some patients can wake up weaker. I mean, I was lucky with, right? Like, but certainly ischemic, changes of blood pressure, rebound, edema, right? Like also, that's another case, 79. See, I'm truthful, not 80, 79. Old man with neck pain, quadriparesis. This patient had a pannus in the context of instability. You can see the spinal laminar line here. Obviously, you assess that with an X-ray, not an MR, but this is clear that there's an increased ADI, and that's the cause. The instability is the cause of this pannus, so it's not necessarily a degenerative pannus. It's just pannus resultant from instability, and that's the post-op scan. Same thing, resolution of this massive pannus, or near resolution with excellent decompression. Another lady, 87, no rheumatoid arthritis, presenting with quadriparesis, pretty functional, pretty smart, massive pannus behind the C2. This is in the context of C1, C2 instability. You can see here. C1 was almost destroyed, so there's no points of fixation for me to have. So I went up to the occiput, and same thing, resolution of the pannus. Now we talked about the four horsemen, but definitely other diseases or spinal conditions may affect octogenarians. Actually, all of them. And the question, sometimes the dilemma is in urgent scenarios, what to do with these patients. Should we pull the trigger on a big operation? Shouldn't we? And it's a case by case. And I'll present some cases here, and we'll hopefully make it a little more interactive here. Thanks, Alex, for joining. It's always good to see you. So this is an 84-year-old man with lower extremity weakness, history of non-small cell lung cancer, spastic paraparesis, hyperreflexia, numbness in the legs, progressive over the past 3 weeks. You can see here 2, 3, 4. T2, pathologic burst fracture causing stenosis, spinal cord compression. Okay, so what should we do here? What's your philosophy here, Alex?
Yeah, that is T2 when I count. It's T2. It's pretty hard. It's pretty hard to go in an old man from anterior far down for corpectomy. So this would be a laminectomy, T3, T4, and stabilization. And I can discuss a lot what to do with the stenosis, maybe asymptomatic between C2, 3, 3, 4, 4, 5. But this is, for me, it's a posterior only case. Just decompress the spinal cord, do a fixation, and I would dare to go interior in these patients.
Yes, same philosophy. So 84, right? Like you got a palliative, right? Like, so, but he's life expect like prognosis. So when we're treating just for everybody, when we're treating spinal metastasis and you have a diagnosis, two things: Karnofsky score, and the you got to look at that as well as the prognosis. And if the patient has good prognosis, good functionality, surgery is an option for palliation. And when do we decide to operate as an option for palliation? When you calculate the SIN score and stability score. And certainly this is unstable spinal cord compression. There's no integrity of the anterior or posterior columns. So along the same lines as Alex noted, I'm not gonna go too crazy. So I did a cervical thoracic fusion. laminectomy, pediculectomy on one side, and they went from the front and removed like a separation surgery. I didn't want to put a cage. This is his scan 18 months later. I think cancer-free. Very lucky. So he did well. Sometimes like if it's a significantly morbid operation and you can't get the patient through the perioperative period, that's very bad. Like you need to get them to radiation. Okay, so you need to give them a stable enough construct to get to radiation. Not every patient needs a corpectomy. Not every patient needs a front back. And you got to give the patient a reasonably biomechanically sound construct, but not super aggressive, because the more you do, this patient has a wound dehiscence, issues, longer hospital stay, DVTPE, they won't get to their treatment, which is actually radiation and chemotherapy. So that's one case.
Nader, may I ask you a question, just a technical question?
Sure.
In these patients, we often face the DJK problematic. What is your concept for the LIV? Do you put some cement in, long screws, or what is your thought process to prevent DJK?
To prevent DJK. So in the degenerative, in the context of degenerative disc disease and deformity, certainly I want to pay attention to it, you know, but within the context of oncology, spinal oncology, you know, I don't want to waste too much time adding cement and adding. So these are two different populations. I'm more aggressive paying attention to it and soft landing and maybe perhaps cementing the bottom screws, making sure that the screws here are like not necessarily this way, more horizontal. All that stuff really counts more for patients or non-cancer patients, because you can spend more time perfecting that and paying attention to like adding cement and, you know, if it's UIV, maybe a tether and so forth. For cancer patients, if the bone quality is acceptable, that's what I would do, because I really want to get them off the table and heal and treat. But haven't had an issue with cancer patients coming back for failed constructs for some reason. Like it's super rare for someone who've had an operation to come back with like broken rods. You know, if a patient has been treated for spinal metastasis. Different story if it's a kyphosis or kyphoscoliosis or deformity surgery or long construct for just degenerative disc disease. What do you think? What are your criteria?
Yeah, it's the same. Yeah, in tumor patients, in trauma, we say damage control. Yeah, so go in quickly. Don't do too much stuff that can lead to wound dehiscence or wound infection. As you mentioned, delay of radiotherapy, delay of chemotherapy, that's not good. You have to prevent this. So fast.
Then it's a poor outcome. The thing is, like with cement, for instance, you got to get the X-ray and you can inject a little bit and then keep going. Like it just adds time. And the more machines, there's a risk of wound infections, right? Like your AP and lateral, and then and then it's so you want to minimize all these things. This is a case that was open up the skin incision, exposure in half an hour, freehanding the screws, doing the decompression, rodding, and we're out.
Yeah.
So this is another 81-year-old gentleman who had significant back pain after multiple lumbar surgeries. He suffered from pseudoarthrosis, little scoliosis. That was not his main issue, but his main issue was pseudoarthrosis. And that's an extensive discussion because he's a cardiac patient. You can see he had like sternotomy here and wiring, what have you. So that's an extensive discussion with the patient. But this guy said, I can't continue like that. I have no quality of life. And we counseled him. This is a big operation. You're higher risk. We optimized all his risk factors, and we got him through. He did fantastic, zero pain and follow-up. His issue came back with wound dehiscence due to like he could not tolerate like the stitches, non-absorbable stitches. So we had to revise a little bit his wound like a year after surgery. So counseling, and optimizing patients critical for long segment fusions that are done elective. This is the non-elective case. This is an 87-year-old woman who has fallen, neurologically normal, but you can see here, that's all autofused, and there's a 3-column injury here, through and through. You can see it on the T2 and the STIR, through and through, and she has an epidural hematoma. She's neurologically intact. Severe pain. You put her head at 30 degrees, she can't tolerate. You got to bring her back flat with the neck collar. So we attempted to mobilize her just a little bit in bed to kind of gauge if we can get away with a CTO. Absolutely not. So that's a huge discussion with the family and the patient, what to do, because it's not a small fix. 87, luckily, that's her post-op scan. She fell down. That's over a year ago. Like this is like 15 months ago, something like that. And then I was pulling her images and I noticed that she came to the ED after a fall and they scanned her and everything has healed. You can see even the subluxation. See, that's the step off here, step off here, step off here. Realigned perfect. And did well. She's doing well. And here we'll end with this case, and I want to see what do you guys think about this one. This one is an 82-year-old woman with thoracic myelopathy, lower extremity weakness, who presents with this scan. You can see here, pathology front and back. I wish I can zoom in. Can you see it, Alex?
Yeah.
Okay, so this is a patient, 82, spastic paraparesis, thoracic myelopathy, and that's a diagnosis. So fit for surgery, right? Like she's healthy and DEXA scan is reasonable, so forth. So what are the options? What do you think?
Yeah, Nader, this is extensive compression. It's anterior to the cord, it's posterior. But I think it is the principle is how do I get proper decompression of the spinal cord? So it's for me, it's a posterior only. I would take away 2 complete laminae, and because of 2 level laminectomy, I would add stabilization as well. Perhaps I can do a combination of MIS, percutaneous stabilization, and a midline incision for the 2-level laminectomy. I would not go for anterior corpectomy. You can do it. You can always do a lateral or posterior corpectomy, but in my experience, it's enough to do the laminectomy and stabilization. I would not do laminectomy only. It's too critical for me. Maybe the anterior compression gets worse, and stabilization is the cure for or the anti-progression cure of this pathology, in my point of view.
I can't agree more. You have the same philosophy as I do with treating these things. So 82, we don't want to go too crazy. A decompression and fusion. And I'll show you the post-op scan. Ready? Okay, this is it. Along the same lines, we think the thoracic spine is stiff. It's not that stiff. I mean, it's stiffer than the lumbar, the cervical, but you can see along the same lines, ventral pathology disappearing with a fusion, okay, and a decompression. So this woman would have had, like, you know, if someone would have done a 2-level corpectomy, super morbid, unnecessary. I don't want to say super morbid, but more it's morbid, right? Like thoracotomy and going in and the 2 approach and then coming back. Not necessary. So you can see here, have faith, posterior decompression and fusion. Chances of things resorbing versus not resorbing, chances are they're going to resorb ventral pathology because of the stabilization. So that's all I have, everybody. Thank you for joining us. Please, let's see if you have any questions in the chat box.
Yeah.
You guys hear, right? Like, okay, good.
Nader, I want to ask you, what is old in your patient's population? What is old in Chicago meaning? Is it like 80 to 85, or do you have a lot of nonagenarians? Is octogenarian old
So
for you?
where I practice right now, so the suburban Chicago suburbs, west of Chicago, let's say 35 miles, 40 miles west, static population, different demographic, definitely older on average, definitely older. So this is my practice over the past 18 months, less than 18 months, 15 months. So downtown Chicago, where suburban Chicago, I would think on average I'm treating 8 to 10 years older. So many more patients in the octogenarian age group. Definitely 90s or above, they exist, but I have not operated electively. Maybe once, one minimally invasive decompression on a 90-year-old gentleman. That's about it. But definitely the prevalence, the population in the Chicago suburbs, patients getting healthy and healthy patients in the octogenarian age group is definitely more prevalent than downtown Chicago. The demographic is very different. So.
Yeah. And Dr. Tribula is asking in the chat box an interesting question about the cognitive issues of patients undergoing these kind of surgeries. Do you do some pre-op assessments? Do you use just a minimal test to look for a delirium score? Can you comment on this?
Fantastic question. That's definitely almost needs to be screened. So far, there's no specific protocol that I follow, but often these patients, they have their significant others and their children with them, and we counsel them about delirium after surgery. I haven't seen it much, but it can happen. But also, if there's any questions like, there's some memory loss, I need a formal neurology consult for cognition, because if there is dementia, even mild, that's a different story. I avoid operating on patients. Unfortunately, I don't like to say that, but I avoid because the outcome is not good, because it worsens substantially after general anesthesia, particularly longer surgeries. So almost an exclusion criteria, someone with dementia having elective spinal surgery. Very reluctant even with emergency surgeries, right? Because now you're putting them on ultra risk, significant risk of complications and delirium and prolonged hospitalization. So I avoid doing surgeries in patients with cognitive dysfunction before surgery. Patients without it, I counsel them about the possibility of delirium.
Yeah, but I think we have got a number of patients in nursing homes who are not evaluated. They are bedridden for years, absolutely no candidates for surgery. But I think this myelopathy is really something we have to look for in our geriatric patients populations. Sometimes we are caught when the patient is in internal medicine for respiratory insufficiency. They get this CAT scan of the chest, and then we see a severe stenosis incidentally, let's say incidentally on this CAT scan. But in fact, the patient has got a thoracic myelopathy. We always say look for cervical myelopathy, but I guess we have got a high number of undiagnosed thoracic myelopathies as well here in Switzerland. Octogenarians, nobody gets them to the doctor, nobody gets them to the surgeon for good reason, But the quality of life is really bad if you're suffering from thoracic myelopathy, and all these diagnoses like restless legs, polyneuropathy, or it's just age. It's difficult, and dementia and a process is a good reason not to operate. But on the other side, it's not a good strategy to let them go into paraparesis just because of a cognitive decline. It is so difficult. I don't have a good answer to solve this problem.
Yeah, it's a tough one. It's a tough one. I'm reluctant. Like dementia, it's just a different ball game. My experience hasn't been good with those, so that's. I mean, and I hear from my colleagues as well. Now, there's a good question in terms of outcome in patients after surgery. How good is the quality of life after these invasive procedures? Are there any fault? I'm not aware of a long-term follow-up study, but my experience here has been fantastic. Otherwise, I wouldn't be giving this talk. So I think the outcome is tied to the appropriate diagnosis. Okay, so the right diagnosis, right treatment, right good outcome. Comorbidities are tied to the complications. So as long as the patient is healthy, bone quality is good, all risk factors are optimized, they're cognitively sharp, we can get them through very well, reasonably. Definitely, less is more in this patient population. So a decompression versus decompression fusion, everything is the same. Go for a decompression. Corpectomy, avoid doing it, right? Like a transthoracic, anything that adds too much time, avoid doing. But all these patients that I showed, for the most part, they did fantastic. This one lady, unfortunately, she started having cognitive problems like maybe a year after surgery, just mild. Before the surgery, she is ultra sharp. So that's all I have.
I think a good outcome is when the patient can stand and get an upright X-ray in the post-op follow-up control. Because what happens if you don't go for surgery in this patient with a ankle spondy subluxation or luxation fracture? What is the history, the natural history, if you don't go to the OR? It would be paraparesis. And
or bedridden, bedridden forever.
Bedridden, and so a misdiagnosis is the natural history. And if I see an upright X-ray, a standing patient is a good outcome per se. It looks good.
Yeah, good. I agree with that, Alex. Good. All right. Do you know who's presenting next week? We'll find out maybe on X.
Oh yeah, I can say next week is holidays. Next week there's no conference. We see again in 2 weeks.
In 2 weeks, whoever was assigned next week is off the hook here. All right, guys. Well, I wish you everyone happy holidays, and thank you for joining us. Thank you, Alex. Always good to see you, bud. And then we'll see you in a couple of weeks. Have a good night.
Thank you, Nader. Excellent talk.
Good to see you, buddy. Thank you.